Where is my... I should be off there. Let's stop sharing for a second because I lost one of my tools when I did that. There's my record. All right, now I'll share it. All right, I'm going to just count down from 5, and I'll not say 2, 1, but I'll stop sharing at uh, 2 and 1, and then you just start, okay?
Okay.
All right. 5, 4, 3.
Hello, my name is Candace Bowman. I'm the Senior Director of Home Health and Emerging Care Models for AuthoraCare Collective, located in Central North Carolina in our Piedmont region. I have the pleasure of overseeing our Home Health Division, where it allows us to practice evidence-based clinical quality care for the patients that live in our community. I also have the distinct pleasure of building and implementing our Guide Dementia program. So GUIDE stands for Guiding and Improved Dementia Experience, and it truly does for the caregivers and families of dealing with this chronic disease. So in early 2024, CMS designed this model and developed 2 tracks. One was a new track, which allowed agencies to come up with their program and how they were going to implement it and operate.
All right, we can stop.
Sorry.
That's okay. Um, I want to make a change anyway,
Okay.
because your title has changed.
Okay.
What is your title now? Senior Director of what?
Of Home Health and Emerging Care Models. Do I need to slow down a little bit?
No, I think your pace is good.
Okay.
Home Health and Emerging Care Models. Got it. Because that didn't match. All right. Try this again. Let me share this screen. And just like last time.
Okay.
5, 4, 3.
Hello, my name is Candace Bowman. I'm the Senior Director of Home Health and Emerging Care Models for AuthoraCare Collective, located in Central North Carolina in our Piedmont region. I have the pleasure of overseeing our Home Health Division, which allows us to practice evidence-based quality care for the patients that live in our community. I also have the distinct pleasure of overseeing our Guide Dementia program. GUIDE stands for Guiding and Improved Dementia Experience, which it truly does for the family and caregivers of patients suffering with dementia. In early 2024, CMS designed a program to help take care of this patient population. There were 2 tracks that CMS allowed agencies to apply for. One was a new track, which allowed agencies 1 year to build their program, to hire their staff, and operationalize their dementia program. The other track was an established program, which indicated you already had a dementia program and were taking care of this patient population. AuthoraCare was deemed an established program, which meant we could hit the ground running July 1st, 2024. And that's exactly what we did. We hired 3 non-clinical navigators to service these patients that covers our 13-county region. We quickly grew and have now increased our navigators to 4. Our census right now is currently around 200, and we're excited to continue to serve this patient population within our community. When we first started, there were 2 things that really jumped out to us that we needed to make sure that we focus on: efficiency and empathy. So we needed to start with the intake process. Let's start at the beginning, right? So we needed to make sure that we created a place for honesty, for transparency. So our first major learning came through the admission visit. Initially, our admission visits were taking about 2 hours. We were gathering all the assessment data, making sure we included all the information that could help take care of this patient. But what we realized was something deeper was needed. When we were completing the caregiver burden tool, we were asking caregivers about the burden in front of the loved ones. This was not a good idea. It created hesitation, guilt, and oftentimes silence. So we needed to streamline this process. So the first thing we did was centralize our referrals through a standard intake process. We implemented electronic consents. We developed an electronic caregiver burden tool using the ZBI interview, which could be completed privately and prior to the interview. This one change made such a meaningful difference. Caregivers could honestly answer the questions without worrying about hurting their loved ones. It helped the navigators also gain better insight and clearer prompts to ask better questions for more meaningful support. As a result, our assessment visits are now closer to 90 minutes, much more efficient, but also more focused. Our navigators can spend less time on paperwork, more time on case management and patient connection. Efficiency didn't reduce compassion. It strengthened it. Caregiver support. This was a major need for this patient population. It's impossible to ignore. Caregiving for someone with dementia is exhausting. The emotional, physical, and financial strain is so profound. We heard it in story after story. And very quickly, one need arose to the surface. These caregivers needed respite. Caregivers didn't just need information, education, they needed relief. So we built a very robust respite care network across all of our service areas, partnering with local home care agencies and adult day centers. We developed a standardized referral process, increased the number of partners to make sure we could meet the demands of our patient population, and established clear invoicing and reimbursement workflows to make the process seamless. We also hold monthly touch points with all our respite partners, sharing success stories, addressing challenges, and ensuring quality care delivery. Most importantly, we actively encourage eligible caregivers to use the respite services, not as a last resort, but as a proactive strategy to sustain their well-being, because the caregiver health directly impacts patient health. Support groups. Let go of the agenda. So our third learning came from our first caregiver support group. We planned it out so carefully. A structured 2-hour sessions that had education, icebreaker games, and lots of community resources for our caregivers. But about 30 minutes in, something shifted. Caregivers began sharing their stories, the stress, the safety concerns, the moments of doubt, the resources that worked, and then there were ones that did not work. Heads were nodding, people were leaning in, there was recognition in the room. So we did something very important. We let go of the agenda. The group evolved into something far more powerful than we had ever planned. It became a space for connection. When we reviewed post-event surveys, the message was clear. Education's helpful. The resources were very appreciated. But what mattered most was just being heard. Now our support groups are more designed around that lesson. They are conversation-driven. We still offer education and tools and resources, but we follow the needs of the room. And we've added a virtual option to ensure all caregivers can participate in more rural areas. Connection is not a side benefit, it's central and imperative. If we had to summarize what implementing GUIDE has taught us, it's this. Standardization creates efficiency, but listening creates impact. By streamlining our intake process, strengthening our respite partnerships, and reshaping our support groups around the authentic caregiver needs, we have built a program that is both structured and deeply human. And in dementia care, both are essential. Thank you.
I think that was great.
Really?
Um,
You do?
yeah, and I'm not sure how like let's see. Watching now, streaming started 9 minutes ago. Let me just see what I can edit the video. Let me just go back and let's see. That is called Smart Ground. Right. I think that we have what we need. I just need to go into my end now and play with editing it a little bit. And I will get that done and send it back to you. And then if you're pleased with it, then we'll just forward it on. But I think it's going to be great. I think you got it.
Okay, well, I'd value your opinion, so
All righty. Thank you.
thanks, Bob.